So Laurent Fiorina, I work as an EP in Paris, and I will show my work about unmasking conduction tissue disease with an AI-enabled single-lead ambulatory ECG. So the importance of this study. Imagine that you have a patient coming to you days after a syncope, and the telemetry and the ECG are normal. Now imagine that you can process a few hours of ECG recordings, and the AI model can tell you your patient has had complete AV block in the 2 previous weeks. So syncope is a frequent condition, and we know that it's challenging, time-consuming to make the diagnosis. So there is an effort with my team to develop what we call ECG digital biomarkers. Those are AI models that use ECG to do basically 2 things: to detect a cardiac condition like a structural heart disease, and secondly, to predict a future occurrence of a cardiac event like atrial fibrillation or ventricular tachycardia from a normal, apparently normal ECG. And so the Back to the Future concept was inspired by the challenge we face when we have a patient who experience the syncope in the prior hours or days. And what we would really like to do is to record the ECG in the past, to look back into the past, to record the ECG at the precise moment and not when it is too late. And we had the intuition that AI could be that time machine by decoding electrical markers that are the footprint of conduction tissue disease. And with ambulatory ECG, we could detect the structural abnormalities, but also the dynamic changes that reflect the conduction tissue fragility and the autonomous nervous function system. So Cardiology is an AI ECG analysis medtech founded in 2014 and acquired by Philips in 2021. The Cardiology Holter dataset contains more than 3.5 million different ECG recordings. And the first thing we done is an AI ECG analysis platform for Holter analysis. And now our last focus is developing those new AI models to predict a cardiac condition or future cardiac events like atrial fibrillation or ventricular tachycardia. And this is what we want to do with conduction tissue disease. So upon 1.4 million different ambulatory ECG, whatever the indication, after excluding the ambulatory ECG under 2 weeks and without asystolic pause, we finally worked on 340,000 Holter ECG of 2 weeks from 6 different diagnostic facilities in the US. The mean age was 60.5 years old and 60% was female. We then split it into 3 datasets. The development dataset for the model training, the internal dataset for the performance assessment, and then the external validation dataset, which is important because it is an independent dataset to show how the algorithm generalizes in a different population with different device that has not been used in the development dataset. So we take the 2 weeks Holter recordings, and the input of the algorithm is the last 24 hours without any asystolic pause. And we then annotated each recording whether there is or not asystolic pause in the first 13 days. And we use it as output. So the output was either complete AV blocks, daytime sinus pause of more than 3 seconds, or anytime pause of more than 6 seconds, and the composite of it. Well, our key finding is that we reach an AUC for the composite endpoint, which is AV block and sinus pause. We reach an AUC of 0.89 with a consistent result in the external dataset, which shows the generalizability of it. And we can look more precisely into the mechanism with the performance of the prediction of daytime sinus pause of more than 3 seconds, anytime pause of more than 6 seconds, and complete AV block. And for complete AV block, we have a sensitivity and specificity of 81% and 72%. And we can adjust this threshold on the ROC curve to get a higher sensitivity or higher specificity. And it's not, is it perfect? Certainly not, but if I may remind you, the performances of the EP study, which is still in the guidelines and is invasive, we have a sensitivity and specificity of 15% and 75%. Well, we have here a new strong predictive model, but still it does not give a definitive diagnosis. But this is the case for many tools we use in medicine, especially for syncope management. Then we'll still have work to do because cardiac cause is not the only cause of syncope. Then, as we identified complete AV block and sinus node disease, we still don't know the organic or reflex nature of it. And then we will need prospective study to extensively validate the model. And for the perspective, obviously the first perspective is to improve the patient outcome with a non-invasive diagnostic of the syncope cause, to avoid future risk with an early treatment strategy. And outside of the syncope, we could use this model to make a risk stratification for patients having bundle branch block, which one is at risk of developing complete AV block and in what time frame. Then this is a possibility to improve the emergency department triage with the telemetry for rule in or rule out, and to avoid unnecessary hospitalization or readmission. And then you can imagine to combine this AI model with other AI ECG tools like prediction of ventricular tachycardia, detection of structural heart disease, and to combine it with also the clinical context, the lab exam, and the imaging. So my key take-home message is that with an AI-enabled single-lead ECG, we can unmask conduction tissue disease. And this is a hope for a better management of our patients who experience syncope. And also it's a hope to reduce preventable morbid mortality.